Goodness, I think he knows my CV better than I do. That sort of background. Okay, so some of the material I'll talk about will overlap with the material that Pat's just been speaking about, but hopefully I'll be able to get into some of the aspects of this area of research in a little bit more detail. So I wanted to focus particularly on the high risk for psychosis group that Pat McGorry was just speaking about. This is a slide that Pat presented, just to illustrate the idea that the type of patients we're talking about here are young people being referred to our services who generally present with sub-threshold or attenuated positive psychotic symptoms. So we're talking here about people who might be becoming increasingly suspicious, for example, but not to the point where you'd call it a full-blown, paranoid symptom, or, for example, experiencing some perceptual abnormalities, but not to the point of experiencing hallucinations. So that's the sort of group we see at the ultra-high risk clinic in Melbourne called the PACE Clinic. And as Pat said, there are also some other groupings that define this high risk for psychosis group, including those with a family history of psychosis and also those with a so-called psychotic blip who have experienced sort of full threshold psychotic symptoms but for a very short period of time, and they've resolved without treatment. So that's the population we're talking about, and this has really exploded as an area of research over the last 15 to 20 years or so. This is just a figure that summarizes the number of publications in this area, and you can see it's a sort of Manhattan skyline type thing, but just increasing in the number of publications per year. So this has really become a really premier focus of a lot of psychiatric research nowadays. If you go to schizophrenia conferences, a bulk of the presentations will really be focused on this so-called prodromal or high-risk period of psychotic disorder. So I just wanted to focus on the prediction aspect of this area of research rather than the intervention aspect of this area of research. I guess those are the two areas we focus on mainly. How can we narrow down on those within the high-risk group who are at the highest risk of going on to develop schizophrenia and other disorders? And the other area, as Pat mentioned, is how can we intervene in this group to reduce the risk of psychosis and other poor outcomes? So I'll just focus on the prediction side of things in two areas of research in particular. The first one was the so-called PACE 400 study, which we've published a number of papers about. It's simply called PACE 400 because what we sought to do in this study was to try and recontact approximately 400 ultra-high-risk patients who had seen at our service about 2 to 15 years after they first came into the service. So you can imagine the challenge involved with that sort of thing. And I could advise that Facebook is incredibly useful when it comes to trying to recontact that number of patients, particularly in the youth age range. I guess Facebook was incredibly useful for this sort of tracking approach. Okay, so the time to follow up was a mean of 7.5 years after they first came into the clinic that we were able to recontact this group of patients with quite a large range of 2.5 years through to 15 years later. So some of them hadn't been seen for quite a long period of time. There are a range of outcomes we were interested in, but the main one, I guess, was the rate of transition to psychosis. And this is a figure that summarizes what the story is there. You can see from the graph that most of those who went on to develop psychosis actually did so in the first couple of years. That's the sort of steep curve you can see there, and it leveled out as the years progressed. But still, there were transitions to psychosis up to 10 years after the patients came into the clinic. So these are just the figures summarizing that data. So over the first couple of years, we had 20 and then 25% in 3 years who developed psychosis, and 10 years later, 35%. So one of the things we were interested in is seeing whether we could predict that subgroup, that 35% who went on to develop psychosis or not. And so we looked at a range of different measures. There were clinical measures. We took a baseline, so entry into the services. There were neurocognitive measures, neuroimaging variables, and also at follow-up we were able to take some genetic measures as well. I'll just focus briefly on the clinical side of things. So there are a whole range of different, pretty standard psychiatric measures that we used when the patients first came into the clinic. The CALMS here is an instrument that we developed to rate and measure prodromal symptoms in particular. And when we did a sort of multivariate analysis with these clinical measures sort of controlling for the impact of each of the variables, we found that these were the strongest predictors of who went on to develop psychosis and who didn't. So we can see the baseline year of entry, basically those who came into our service in the earlier years of the service, so in the mid-90s through the late 90s, were at a higher risk of going on to develop psychosis than those who came in more recently. Poorer functioning, those who came into the clinic with lower GAF scores, were at higher risk of developing psychosis, and also a longer duration of symptoms before people came into the clinic. Those individuals were at a much higher risk of transitioning to psychosis over that follow-up period. This is a table that just more or less tells the same story. It just breaks down the statistics of each of those variables. We probably don't need to go into the details there. Now, we conducted a sort of a follow-up analysis removing the GAF score from the equation, because the GAF is a very general measure, a very broad measure that's, includes a lot of symptoms and functioning all in one pot, if you like. So we removed that and then looked at what other clinical predictors emerged in the analysis. And it was unusual thought content, so things like emerging suspiciousness, perhaps grandiosity, these sorts of symptoms predicted transition to psychosis, and also negative symptoms when people came into the clinic. Social withdrawal, anhedonia, and so on predicted the transition to psychosis in this group. So we followed up that main analysis with a number of other studies, and these sort of a list of the types of features that predict and variables that predict who in this high-risk group seem to be at high risk of going on to develop psychosis. We found a number of factors here. So childhood sexual abuse was quite a strong predictor of the group who went on to transition to psychosis. Some neurocognitive deficits. I mean, it should be said that neurocognitive deficits weren't a particularly strong predictor of transition to psychosis, but nevertheless, some could be identified. This has recently been published, structural covariance alterations in discrete neural networks, particularly these networks listed up here. And also some neuregulin genetic variation was identified in the high-risk group who went on to develop psychosis. Now, as Pat mentioned in his talk, it's not just a transition to psychotic disorder that it seems to occur in this high risk for psychosis group. There are also very prominent non-psychotic outcomes. This is published in American Journal of Psychiatry, Dr. Friedman's journal. And we can see that the incident disorders, non-psychotic disorders such as depression, anxiety, range between 10 to 20%, and also high rates of continuous disorders. So in other words, this is a group at high risk of a range of disorders, not just psychosis, as Pat mentioned earlier. So what are the implications of this aspect of the study that I've reported here? I think one of the clear implications is the need for treatment of a reasonably long duration, at least 2 years probably, for this higher risk for psychosis group, because we can see these transitions occur up to 10 years after clinic entry. I mean, the highest risk is within the first couple of years. So providing treatment over that period is definitely warranted based on this data. And also easy re-entry to care, so some ongoing monitoring if the person does deteriorate, that they can re-enter services as easily as possible. Now it seems as though certain clinical variables like longer duration of symptoms, poor functioning, negative symptoms might identify a group as higher risk of going on to develop psychosis. So if we see these so-called UHR, patients coming into clinics with these features, perhaps that particular subgroup needs to be paid particular attention to. And as I said, this approach identifies those at risk of a range of disorders, not just psychosis. Okay, so that's sort of the data I wanted to present about this PACE 400 study. Just in the time I've got left, I also wanted to mention this other area of research I've been focusing on a little bit, and it's been well funded actually by the Brain and Behavior Research Foundation, so I thought it would be appropriate to mention it. So it's through several NARSAD grants. And this is the area of self-disturbance. So the concept of there being a disturbance, a disorder of a sense of self in schizophrenia and related disorders has a long history in this area of research. So, going back to the very early days, in German phenomenology and so on, there's a lot of concepts were introduced that are consistent with this idea of a disturbance in a basic form of selfhood, and it's been promoted in more recent years by a group of Danish researchers, and also Louis Sass has written a lot about this idea as well. And the type of self-disturbance that's being talked about is a very basic sense of self. So we're talking about a simple first-person perspective on experience, a quality of mindness or sort of an ownership and sense of agency of experience. And all of these things are very implicit in normal experience, if you like. And that's distinct from what is often referred to as the narrative self, which are things like social identity, personality features, those sorts of things. And the theory is that this sort of basic sense of self is somehow perhaps unstable in the schizophrenia spectrum. In 2005, an instrument was introduced called the EASE, the Examination of Anomalous Self-Experience, that enabled us to sort of measure this concept in a reasonably valid and reliable manner. So we used that in the ultra-high risk group to see whether it's a characteristic feature of this clinical population, also whether it predicts transition to psychosis or not. Which I've got listed up here, the range of different types of subjective experiences that are captured in this scale. Just run through them very quickly. We talk about disturbed stream of consciousness or cognition. We're talking about sort of subtle forms, for example, of thought interference or thought pressure, those sorts of experiences. What's called disturbed presence, and which is this idea of not feeling fully alive in the world, not participating in the world in the way that most people, is a feature of normal experience, if you like. Disturbed bodily experience, so rather than sort of inhabiting one's body and in the way that is part of normal experience, relating to one's body and physical experience more as an object or as a third-person experience of the body rather than an inhabited first-person experience. Self-demarcations, so sort of self-other or self-world boundaries seem to be a little bit amorphous or less stable. And existential reorientation, the idea of being preoccupied with very existential, metaphysical ideas that you often see in the early phase of psychotic disorders. Okay, so briefly what we found was that this scale did predict transition to psychosis when other predictive variables such as long duration of symptoms and poor functioning were controlled for. So there seems to be something going on with this self-disturbance concept. And there were particular aspects of the scale that seem to account for the overall predictive value of the EASE. Other aspects of data indicated that it seemed to be quite specific to schizophrenia spectrum cases. And this is consistent with the idea that this form of basic self-disturbance is characteristic of the schizophrenia spectrum rather than psychosis more broadly. And also that it wasn't particularly prominent in those with borderline personality disorder. You could argue also have a form of self-disturbance, but maybe it's a different type of self-disturbance. So one of the things I've become interested in the last couple of years is the question of, okay, well, if there's something going on here in terms of self-disturbance being prominent in this group, what actually drives it? What's responsible for this phenomenon? Of course, there are developmental factors that might play a role. There's a body of research around this concept of multimodal integration, which is the idea of how senses might link up and integrate and form a first-person perspective. So how do we integrate the sense of touch and sight, for example, as infants through the developmental years? Possible neurocognitive dysfunction and neurobiological processes. And what I'm focusing on at the moment in research is the possible neurocognitive dysfunction. And this work is actually supported by an ASAD Independent Investigator Award at the moment. So this is the model we're trying to test, is whether we hypothesize that source monitoring deficits, so the ability to distinguish self from other, and the self from world is perhaps askew and related to the development of basic self-disturbance in some way, and also aberrant salience, which has been quite widely talked about in the psychosis literature, over the last couple of years we hypothesized might be related to the development of basic self-disturbance. And aberrant salience is the idea of certain features of the environment or of one's internal experience taking on unusual sort of prominence or significance in the sort of field of awareness. And we thought that these aspects might drive, self-disturbance as well. So we don't have any data to present around that side of things at the moment, but hopefully in a year, or so, we'll be able to update you on whether that model has some viability or not. We're conducting a pilot study at the moment with a group of ultra-high risk and first episode patients. We hope to follow that up with a larger scale study. So I'll wind up, but I think in terms of future directions in this area, I think one of the important points is the need to replicate predictors. I mean, if you look at a lot of the work in this area, it's quite exciting when you see a bunch of new predictors emerging, but they're not always well replicated. They don't appear again in the next study that comes along looking at predictors. So this is very, clearly a very important thing to achieve. Multimodal prediction, what do we mean by that? The idea of integrating different domains of analysis or assessments, if you like. So how do the clinical measures link up with the neurocognitive measures, with the neurobiological and genetic measures and so on, and how do these things together increase our ability to predict transition to psychosis? So that's another area of research that's been focused on at the moment. And cross-domain integration, that's something that I'm very interested in. How does the phenomenology of psychotic disorder link up with the neurocognitive disturbances that we see, the neurobiological disturbances? There's a real need to integrate these different levels of analysis, in my view. And this is just a figure from one of our colleagues, Scott Clark at the University of Adelaide, that just illustrates that idea of how multimodal integration might be of practical utility in predicting outcomes. So how does the clinic, can we improve on the clinical assessment of the UHR criteria through introducing neurocognitive testing and then introducing MRI scans, for example, and so on. That through these various steps in the assessment process, we might be able to improve our prediction of outcome. Again, to sort of emphasize the ideas that Pat was talking about, a lot of this prediction work in the UHR field might assist us in sort of narrowing down on those within the high-risk group who are at highest risk of developing psychosis. And you see through this red triangle there, so narrow down on this subgroup, if you like. And of course, the implications of that is that it'll help us understand the mechanisms responsible for the onset of psychotic disorder, and also have implications for treatment. So this is a slide that Pat showed as well, and I stole it from him actually, which shows that as in other areas of medicine, if we can identify the level of risk within the high-risk group, then that might have implications for the types of treatments that are introduced. Okay, so I'd just like to acknowledge, the team that plays a huge role in gathering all this data. I mean, these are large-scale studies. We've got, a whole host of people involved in this area of research, and of course, our funding bodies as well, in particular the Brain and Behavior Research Foundation. So thank you for your attention.
Great. Questions for Dr. Nelson? I guess if you come down. This may not, if you want to come down, we've got speakers right over here. But maybe this may not be a fair question, but I'm going to ask it anyway. So when you identify these young people and they're becoming more psychotic, what do you do for them, or what is done for them with regard to treatment?
Sure. Well, we've got quite a comprehensive model that we use, a psychosocial-based model. So case management, doing the practical needs of the young patients coming in, for example, assistance with education, accommodation, those sides of things. We provide psychotherapy, so generally cognitive behavior therapy for this group, antidepressants if they're indicated, and we withhold antipsychotic medications with this group. I mean, the evidence base at the moment is that antipsychotic medications are not warranted with this group. The sort of cost-benefit ratio is not favorable in terms of side effects and actual benefits that they bestow. So yeah, that's the general approach. It's a team-based approach.
Sure.
And, yeah.
Well, there's a yes, sir.
Good morning, sirs. You have mentioned German phenomenology. The German philosopher Hegel had a schizophrenic sister, so I asked, when does schizophrenia end and philosophy begin?
Now, did you say when does schizophrenia and philosophy begin? Is it,
Sorry, when does schizophrenia end and philosophy begin? Because
where does schizophrenia end and philosophy begin?
yes, because Hegel, the person most famous for this German phenomenology, it is said that his sister was diagnosed with schizophrenia. So I asked that question to you.
Yeah. Well, I mean, that's actually a fascinating area, and actually, according to this sort of basic self-disturbance model, one aspect of it is this idea that's called hyperreflexivity. And Louis Sass has written a lot about this idea, but it's an idea of an excessive sort of awareness, if you like, of things that are normally in the background of our consciousness or experience, things that are normally implicit and we don't pay much attention to. And the argument is that this is one of the things that's going on in schizophrenia spectrum disorders. And perhaps it relates to the ideas that Dr. Friedman was talking about as well, that there can be an excessive awareness of things that aren't normally paid attention to or suppressed in our field of awareness automatically, if you like. And an argument could be made that something similar is going on with philosophy, that a lot of philosophers are paying attention to things and thinking a lot about aspects of life that are normally just assumed and we go ahead and get along with. I mean, the very basis of philosophical thought is to bring those things to light and to sort of pay them more attention and think them through and so on. So I highly recommend a book called Madness and Modernism if you're interested in that area. It's a thick tome, but it's worth getting your teeth stuck into if you're interested in that question. Yeah, but it's definitely, I mean, there's conceptual overlap in the way that these things are talked about for sure. It's schizophrenia.
Okay, thank you. Yeah, we've got several questions and not much time, so let's, yeah. Yes, ma'am.
I have a question. It concerns my son. He was first diagnosed with schizophrenia about 7 years ago. He had a psychotic break, and he is currently taking medication, we hope, consistently, but we can't be totally sure. And he can take care of his personal self, but he totally wants no social interaction. He lives in my home, and it may seem unbelievable, but I rarely see him. He comes out only at nighttime when I'm in bed, and I want to know if some way I can help him to maybe accept more help. He only goes every other month to see a psychiatrist. She gives him the prescription, and that's about the size of it. I've tried to have him see a caseworker. He saw one once, but he wanted no part of it. He's a very highly intelligent young man. He was a graduate of Oberlin, a graduate of Hunter College. I have 5 children. He is the number 4 child. And he was an exemplary student, and I just wonder, how can I help him in any way that I can possibly draw him to accept some sort of more intervention and help?
Well, I mean, it's an incredibly, difficult sort of situation, obviously, and I mean, it's hard to give specific advice about situations like that, but I mean, I think the idea that Pat was talking about before about hope, and the idea that things can change in some way is a real key feature. So I'm not sure if you or somebody else are in a position to sort of distill exactly that sense of hope, then that sort of thing is key. And also developing some form of a trusting relationship, if it's possible, with a therapist in the field, with a psychiatrist or other people to chip away. And sometimes these things take time,
7 years it's been,
Yeah.
I mean, he loves to play chess. He does it online. I mean, he communicates mostly with me through emails.
Sure.
He doesn't want, I only get to see him every other month when I take him for his psychiatric visit. Then I speak with him in the car because I drive him there. And then he's a captive audience. And that's the only time. But I feel like I'm just not doing enough.
Well,
You're probably doing everything you can do at this point, but to
Just
keep
on
working
trying.
away on the
Should I
relationship side of
should
things.
I encourage the caseworker
well,
avenue?
we're not really in a position
Oh, I see. Okay,
to
I
address
understand.
the individual
Okay.
questions, but
But encouraging your son to sort of link in with the services as much as possible, which sounds as though
And
that's what you're
instill
doing at the
hope.
moment.
There's still
I think
hope.
that's the
There is-
key.
That is
and
That's the
he
key.
seems to also go around. I
Okay,
won't
but we're
take
going
too
to we're going to have to
okay,
move
okay,
forward.
all
Okay,
right,
so
all right,
thank you.
Thanks.
Yeah, so we're going to have 2 more. One here and then one there. Yeah, please.
So to the woman who just spoke, I would recommend that you contact the National Alliance on Mental Illness. It is a wonderful organization. Thank you. So either to Dr. McGorry or to you, one of the biggest challenges with young people who are in the early stages of recognizing or not that they have mental illness is resistance to treatment, resistance to even acknowledging, or whether it's anosognosia or denial. How do your approaches facilitate getting young people into treatment?
It's the sort of system that's been set up, and this is, I think, illustrated through Pat's talk, is the idea of services that are very low stigma and very sort of acceptable to young people. So, there isn't necessarily this message that comes across when people are coming into services first on that you are very unwell, you're very sick. This is a sort of hospital-based, system that conveys that. That message that things might not turn out all that well for you. Instead, it's a very sort of easy access set up with a very low stigma environment. So I think that encourages, getting across the message that things might change, and a sort of an encouragement to engage with the services and make them as easy as possible for young people to engage with, and then to take the opportunities as they appear. Once the person's engaged with the service, then you can chip away at the areas that you can, with the young person once they're into services. So that engagement focus, I think, is a real key there, and as we talked about before, the instilling hope, side of things, and making things as acceptable and almost as cool as possible as you can to a young person. They have to enjoy coming, So that's, there's a trick to that.
Those videos help. Yeah.
At last year's conference, a presenter in the morning, I do not remember his name, presented the idea of using the arc of a particular brainwave to predict schizophrenia. And you're talking about predictors. My question to you is, have you integrated this system or even explored it?
I'm not sure of the specific area of research you're referring to, but it may be the EEG side of things. Yeah, we have actually, and the large-scale fish oil intervention trial that Pat McGorry talked about before, we actually took EEG measures in the participants in that study. We're analyzing the outcome of that at the moment, so I can't tell you exactly what the story is there, but yeah, we'll
using
see.
it. That's
Yeah,
all I
we've
want.
used it, and we'll see what the story is in the data in due course. Yeah.
And maybe we'll know next year.
Yeah, exactly. Yeah.
Thank you.
That's right.
A great talk. Thank you very much.